So it is great to be here and to be here with all of you. Dr. Selby went a cappella without accompaniment. I will try and introduce some comments about our conference with some slide accompanying me. Before I do, I just wanted to mention how grateful I am to Joe for his willingness not only to engage in this conference, but the extraordinary way in which he helped to shape and lead it. He may remember that it was a Friday before Memorial Day that my colleague Jill Abel and I met with Joe and Rachel Florence in the Picori offices that had just had their furniture delivered. And we proposed this conference to him, and he really shepherded through the Picori program. I also want to extend my thanks to my co-chair on the Clinical Effectiveness Research Collaborative, Rich Platt, who creates the environment that allows this to occur, and to Claudia Grossman, who made this happen. It wasn't very long ago, just a couple of months ago, we said there is no way we have enough time to pull this together. And although it's a mystery to me how she did it, it has been pulled together, and I'm very grateful to her for having done so. So let me begin with what I do now at every meeting. Maybe you could. And that is make a disclosure that I'm employed by GlaxoSmithKline. And as a result of some previous presentations I have made in public, I am now asked to comment that all my remarks at this conference, both those now and in the ensuing discussion, represent my own personal views and may not represent or reflect the views of GSK. So please keep that in mind. I hope by the end of my own introductory comments to have offended as many of you in the audience as possible. That offense does not come from GSK. So as you are already aware, we are not here to debate evidence hierarchies. I would love to, but we are not here to do that. We are here to discuss how observational studies can help guide clinical decision making. And what is the evidence base that applies to decisions for an individual patient, both when treatment is begun, but also when treatment changes are required. So I am motivated, I have always been motivated by this comment from the Heberden Oration of Austin Bradford Hill in 1965, when one of the great pioneers of randomized trials wrote, "This leads directly to a related criticism of the present control trial, that it does not tell the doctor what he wants to know. It may be so constituted as to show without any doubt that treatment A is on the average better than treatment B. On the other hand," Hill argued, "that result does not answer the practicing doctor's question, what is the most likely outcome when this drug is given to a particular patient?" Now, just as I have always been motivated by this quote from Hill, I've also been inspired by this set of questions from Picori that has always highlighted this as part of their information that they have on their website, and it represents in many respects one of the core values of Picori as I understand it from outside of the organization. Questions such as, given my personal characteristics, conditions, and preferences, what should I expect will happen to me from this treatment? What are my treatment options, and what are the potential benefits and harms of those options? What can I do to improve the outcomes that are most important to me? And how can clinicians in the care delivery systems they work in help me make the best decisions about my health and health care? It was these questions that led me to Joe's office on that Friday before Memorial Day. So I don't need to tell all of you. I really don't, but I feel obliged to say so anyway. That the patient in a typical randomized trial is a very stereotypical patient. If we were doing a clinical trial of diabetes, the patients in the typical randomized trial would have diabetes, but very few comorbidities and a limited number of co-therapies. Efficacy of treatment would be judged by control of an intermediate measure, hemoglobin A1C, not by patient outcomes such as death, morbidity, or even more importantly, the patient experience with their disease and its treatment and its impact on their function. The trial would miraculously achieve high levels of adherence. The standard would be more than 80%. And the follow-up would typically be short, less than a year. And little change over that year would occur, either in the severity of the patient's main disease, their diabetes, or in the few comorbid conditions that they might have. But as you know, that's not the typical patient that we care for with diabetes in the real world. The typical patient is a complex patient, a high-cost patient with diabetes, and has 5 or 6 of the usual comorbidities of obesity and cardiovascular disease and maybe pulmonary disease and some rheumatologic conditions, and will be on many co-medications. Treatment choices will not be based on long-term morbidity outcomes, will be based on long-term morbidity and functional outcomes, not simply the control of a hemoglobin A1C. And unlike in the typical trial, where high levels of adherence are achieved, in real-world practice, adherence is difficult. Patients will make frequent changes in their medications, intensifying treatments, reducing treatment, stopping treatment as their health and disease status changes, and each of those changes requires a decision on the part of the physician and patient about how to continually modify the management of their care. So to anyone here who believes that the solution to Bradford Hill's challenge about the average result not telling the doctor what he needs to know, and thinks that the solution to that is the subgroup analysis of typical randomized trials, I say to you, my patient is not in your trials. And to anyone here who believes that the answer to the challenge about the average result is based on the analysis at the time of randomization, I would say that my patient requires treatment changes over time, and I need analyses that are anchored to times when disease worsens or improves. And so observational studies, I would argue, really are indispensable for clinical care. The physicians care for patients in individual longitudinal experiments that look nothing at all like typical randomized trials, and that observational studies, I hope we'll have a chance to discuss, have the opportunity to more closely approximate the longitudinal trajectories that patients experience and that doctors treat. So one of my statistical heroes has always been Jerome Cornfield, and in 1966, Cornfield wrote the following. He said, "I do not believe that anything that is good science can be bad statistics, and conclude my remarks," he said, "with the hope that there are no statisticians so inflexible as to decline to analyze an honest body of scientific data simply because it fails to conform to some favored theoretical scheme." We have assembled here an amazing group of statisticians who would never betray the spirit of Cornfield's remarks here. But he also made another interesting comment the year before, 1965, when he said this about statistical analysis in randomized trials. He said, "Clinical trials have a much more complex structure than is assumed in the classical theory of hypothesis testing. It often happens," he said, "that unforeseen essential complications arise, or the detailed analysis of results disclose interesting but unanticipated relationships, so that the most appropriate statistical analysis is not the test of some pre-specified hypothesis." And I think that will frame some of the very exciting discussion which I look forward to over the next day and a half. Now, this inspired me to create my own bit of statistical art. So this is a T-shirt that says that every randomized controlled trial is an observational study on day 2. And I wanted to be sure that my colleague here, Dr. Selby, would be able to wear one of these. Then my good colleague, Dr. Platt, and that the person who was probably the most insistent voice about the evidence hierarchies would also have an opportunity to show up at the FDA proudly wearing his T-shirt, Dr. Tick. So it's now my privilege to get us started by having us move to the first session, which is really a stage-setting discussion. And it was clear to the planning committee that there was no one who was better prepared to do that for us than one of the members of the planning committee, Steve Goodman. Steve is currently the Associate Dean for Clinical and Translational Research and Professor of Medicine as well as Health Policy and Research at Stanford Medical School. Before joining Stanford, he was a Professor of Oncology at Hopkins, where he was on the faculty for many years, and had joint appointments in pediatrics and biostatistics and epidemiology. He is notable for this meeting as a member of the methodology committee of PCORI. And for me, some of the papers that he has written, things like the knowing of chances and the chances of knowing, a great paper on Bayes factors, have always been touchstones for me about a sensible appreciation for the interface between statistics and the practice of medicine. So it's a great privilege for us to have Steve kick off the meeting with his stage-setting presentation. Dr. Goodman?